All right, so chapter 23, behavioral health emergencies. Side note, every recording should be up on the portal now for you guys too. I think I sent an email about that the other day. You guys go back and start reviewing for your final coming up here in the next month or so.
Got it out.
All right. So behavioral health. Okay. There we go. All right. So EMTs are often care for patients experiencing behavioral health crisis emergencies. We do get a lot of that, and we're going to start seeing an uptick in our behavioral health emergencies coming up in the next couple months. Why is that?
The holidays.
The holiday season.
Winter, cold.
Season.
Yep. Cold, winter,
Poverty.
gloomy.
People that might be homeless, they now are going to be in a different situation than summer.
Yep. Yep. We're coming into that season. Okay. And we had that little tease of it being warm, and then it dropped right off. So people are going to start getting cold here soon. So acute medical situations, mental illnesses, mind-altering substances we're going to come in contact with. And again, Morgan did a great job with toxins, with all that. So trying to get that stuff across, and then other causes as well, and stress. So the myth and reality. At some point, most people experience an emotional crisis. It happens. Everybody's going to go through it at one point in time or another. This does not mean that everyone develops a mental illness. Otherwise, healthy people may sustain acute or temporary mental illness, health disorders. So don't jump to the conclusion that the patient is mentally ill. They just could be having a rough time. All right. The most common misconception about mental illness is that if you are feeling bad or depressed, you must be sick. Right? There are many justifiable reasons for feeling depressed. Divorce, loss of a job, death of a relative or friend. All right, this is a normal reaction to an acute crisis. All right, so again, just because someone makes suicidal ideations does not mean they actually meant it, but don't disregard it. Okay? A lot of times people just feel bad over certain things. Some people believe that all individuals with mental health disorders are dangerous, violent, or otherwise unmanageable. Only a small percentage of people with mental health problems fall into these categories, right? So as an EMT, you may be exposed to a higher proportion of violent patients because they are seeing people who are, by definition, considered of having a behavioral crisis. So communication is key. In some cases, patients will de-escalate when the level of trust is established. Never give false hope and never lie. Someone trying to get back in? Yeah, I think it's Kim.
I got him.
You got it? Awesome. Thank you.
Yeah, Kim's in. Yep.
Right. So although you cannot determine what the cause of the person's crisis, you may be able to predict whether the person will become violent, looking for those key indicators. All right. So defining behavioral crisis. Behavior is what you can see of a person's response to the environment, like his or her actions. So over time, people will learn to adapt to a variety of situations in daily life, including stress. Sometimes stress is so great that the normal ways of coping are just not enough, or the person uses negative coping mechanisms like withdrawal, drugs, alcohol, things like that. So reactions to stress that are acute and those that develop over time can create a crisis. So the change in behavior may be considered inappropriate or not normal by the person who calls 911. So behavioral crisis includes patients of all ages who exhibit agitated, violent, or uncooperative behavior who are a danger to themselves or others. EMS is then called when the behavior has become unacceptable to the patient, family, or the community. So usually, if an abnormal or disturbing pattern of behavior lasts for a month or more, it is a matter of concern from a mental health standpoint. When a behavioral health emergency arises, the patient may show agitation or violence, or may become a threat to self or others. So the magnitude of mental health disorders. According to the National Institute of Mental Health, mental disorders are common throughout the United States, even tens of millions of people each year, affecting tens of millions of people each year. A psychiatric disorder is an illness with psychological or behavioral symptoms that may result in impaired functioning. So anxiety disorders are among the most common mental health disorder. So if you ever look at patient discharge stuff and things like that, you notice that like almost every patient that you take out of a hospital has anxiety for some reason. Or they have in the elderly, like every elderly female, and I worked for Northeast Ambulance way back when we did, we used to call them raisin runs because they were elderly, taking them back to the nursing home. Probably not the best thing to be calling them, but we always had names: raisin runs, renal roundup, things like that. But every single patient that was discharged in the elderly always had major depressive disorder. It's like, well, no wonder why they're depressed. They're in a nursing home.
Right, they're going back to where they don't want to be.
Exactly. But everybody had either anxiety or depression. It's like they're just depressed, so their family threw them in a nursing home.
I have anxiety going to a hospital.
Right? Social and or other phobias, post-traumatic stress disorder, PTSD, obsessive compulsive disorder, so OCD or ODD, right? Another one too, as well. PTSD is real, and we need to be aware of it, not because of our patients, but for our own health. You guys are getting into a field where you're going to see some stuff if you already haven't, or if you haven't already. Right? There's going to be things that bother you. Back in the 80s and 90s, we didn't talk about this kind of stuff. We kept it in, type thing, right? Even when I first started EMS in 99, when I first got my EMT license, you think firefighter wellness and behavioral was ever out there? No. If you talked about that, you were considered a pansy.
Yeah.
Your job was to take it in and deal with it. Not anymore.
Be a man. Be a man.
Exactly. Be a man. Suck it up and deal with it. It's your job. You don't like it, quit. Well, not anymore. Now we have a lot of help that's available. Over the last 20 years, it's definitely grown to being a better community. You have to be able to talk about your problems. You have to, right? Because I guarantee you, even myself, I'm sure I have PTSD. I'm sure something will trigger it eventually at some point, right? And I'm sure everybody else will probably have it at some point in time too. It's just a field of work that we're in. Your first fatal fire, your first pediatric death. Some of them are considered career enders. Okay. You go to a motor vehicle accident, you see a pediatric cut in half. That could be the last call you ever do.
Or go to a motorcycle accident and there's pots everywhere.
Yep. They just had that last night.
Yep. 2 nights ago. Yeah. Yeah.
Was it 2 nights ago?
Yeah. But it was,
It was an
what are
Effingham.
we on? I think it was on, what did we, Tuesday?
25.
I think it was Sunday night.
I don't
25.
think we should be talking about it. That's a relative of Kim.
Oh, I apologize. But again, we're going to come, but going back to that though, it happens. We do respond to these types of calls. And having that ability for us to be able to talk about that for our mental health is the best thing for it. Now, does it have to be a professional?
No.
No, but if it gets to that point where they need professional help, then yes. Okay. I'm bringing this up because we don't talk a lot about this kind of stuff and we need to. And PTSD is, like I said, it's real. So you can talk to your friends, you can talk to your loved ones.
Kevin, I have to say that Sunday when we were in Berlin EMS,
You sound very far away.
I do.
The other wind tunnel. We got ya.
I think it's the ceiling, maybe the ceiling fan.
Probably.
I don't know. Let me shut it off. Hold on. The two guys that, at least that I worked with, I know Atina, we both kind of jockeyed around, but they were both very honest with that, that we talked about, like, how do you separate the emotional side of a call versus treating a patient and not getting emotionally involved, but having the emotions because you're human. They were both really honest about, working with your partner, and you have to learn to trust the people you work with, and you have to be open and say, hey, this call hit me, but you do it in a way after the fact. You treat the patient, you do the job you showed up to do, and then afterwards, if you have to sit in the back of the rig and let your emotions out, that's what you do. Or you talk about the call with your partner. Or they were both like very forthcoming with the fact that, you know, they've cried in the back of ambulances, they've cried with each other, they've held each
Jen,
other
they
up.
got teary-eyed with us.
They did. They were very like open. I was surprised because
Yeah.
two, you know, they're both burly and, you know, just kind of like everyday guys. And they both very openly
Yeah.
expressed their softer side, although they were very matter of fact about treating the patient and no emotions there. But afterwards, they were like, hey, you know, I've cried in the back of an ambulance. He's cried in the back of an ambulance. We've called, you know, been like, hey, I need you. I got to talk about this. And so that was kind of nice to see right out of the gates.
And they
Oh,
talked
that's
about
cool.
how they were doing that so that they were leaving the worst of it at the station and not bringing it home to affect their home
Right.
life. And it really made a lot of sense. I mean, we only got to go on one run a piece, but I got more out of that 12 hours,
Yeah.
like from the emotional side of what I need to be prepared for. And just, it was a really great day.
I'm glad
It
you guys
was
had a
just
good
nice
experience.
to see that, you know, two guys, you don't really, like you said, men don't really express their emotions the way women do. And it was
They
nice
did.
for them to sort of bring up the subject and, you know, share that sort of human side. And I was like, oh, okay, I don't feel so bad if I'm going to be cryy or emotional.
Yeah. Yeah.
So,
We're
Like
not. We're not. We're
they
not
wanted to make sure
robots.
you were right. Yeah, well, that was it. And like Jen saw a situation that wasn't ideal and she
okay.
was feeling for the caregiver. And they were like, feel it, talk about it, then let it blow away. And it was neat. I learned so much.
Yeah.
That's good.
Yeah. It was impressive to see.
Yeah.
Wasn't expecting it. So
Yeah.
kudos to the team up there doing whatever it
Yeah.
is they're doing.
Kev,
Perfect.
you were spot on when you said it doesn't have to be professional. It can just be sitting around after a call and decompressing and just talking about it. And then people will talk about different dynamics of a call, and you kind of like just cycle through, and you're like, okay, all right,
Yep.
yep, okay. And it doesn't have to be like some like professional like in front, it's like a psychiatrist unless it needs to go there. But like just decompressing from a call and talking about the good, the bad, the bot, all the ins and outs of calls. It
Right.
definitely works because I mean, I'm an emotional person. Like I have empathy. That's what they call empathy. You have so when that runs high, it's tough to shut it off, but you do. It's a weird mechanism. It's definitely a weird mechanism.
All right. So, other anxiety disorders are among. My goodness, anxiety disorders are among the most common mental health disorders that are out there. We have generalized anxiety, panic disorders, social and other phobias, and PTSD, and obviously OCD. So the U.S. mental health system provides many levels of assistance to people with psychological conditions. Professional counselors are available for marital conflicts, parenting issues. More serious issues such as clinical depression are often handled by a psychologist. Some of the most severe psychological conditions, such as schizophrenia and bipolar disorder, require psychiatrists to prescribe medications. Right. The most psychological disorders can be handled through outpatient visits, but some people require hospitalization and specialized behavioral health units. I'm not a huge fan of the systems that are out there, where they like to use in-state before they go out of state and make you like Maine's one of the worst. Where they'll send you up to like Fort Kent before they send you like over the border in New Hampshire,
Yeah.
which is a lot closer. So, yeah, but they're out there. There is a process they have to go through. Any patient through psychiatric, some get IEA'd through prayer and complaint. Maine is the blue paper. Remember correctly, blue paper? Yeah. It's been a little while since the Maine stuff. So it's IEA in New Hampshire, blue paper in Maine, and I almost said section 12. That's not it.
I think it's a pink slip in Mass.
Oh God. It's section something. Section 12. It is a section 12.
Yeah, it is 12.
I
You're
believe
right.
it's
All right.
sanctioned.
What was that?
I believe it's sanctioned, not section.
Maybe I thought it was section 12. You always call it sections down there, but it could be sanction 12. But either way, though, I mean, every state's a little bit different, but they all kind of like the same thing. Just different names for it. And those are court orders. Now, people can go voluntary too. That's actually some of the best ways to do it is voluntary. But if not, and the patient is just deemed unstable, if you want to call it, then we have to have it done through New Hampshire or through IEA. That does take some time. But as an EMS provider, you can deem them not what's the what word am I looking for? It's not credible. I'm drawing a blank.
Not.
Why can't I think of it? The cold is getting in my blood vessels in my brain. They can't make their own decisions. Leave it at that. And you can have them taken to the hospital that way after talking with medical control, right? And there are ways to do that. So social and situational stress. So behavioral disorders that may have underlying causes. So social and situational stress, such as divorce or death of a loved one, diseases such as schizophrenia, physical illnesses such as diabetic emergencies, which you'll come across a patient with like hypoglycemia, which are very combative at times, or they're just completely unconscious. Chemical problems such as alcohol or drug use, biological disturbances such as electrolyte imbalances, and sometimes these conditions are compounded by non-compliance with prescribed medication regimes as well. So as an EMT, EMT is not responsible for diagnosing the underlying cause of behavioral crisis or emergency. We are not trained to do so. Our job is to get them to the hospital so they can meet with a professional. You should understand the two basic categories of diagnosis a physician will use will be either organic, physical, or functional, psychological. Right. So if they go to, let's say, a local hospital in New Hampshire, they have to be brought in, but they brought in by EMS or PD. They have to be evaluated by a nurse. They have to do a chemical test. They have to do a pee test and a blood draw. Right. They get put into paper scrubs. The physician then has to come in and meet with them to deem them either they need to be seen by, let's say, Northern Human Services, or their physician can have a consultation with Northern Human Services as well and send them home. Once they deem it's a psychiatric issue, then they do what they call teleconferencing. So they'll have like a telemedicine come in through Northern Human Services. They'll meet them through a television, have a conversation for like 45 minutes to an hour, sometimes longer, sometimes a little bit shorter. The evaluation is then written out, and then it's determined whether or not they are going to be put on a voluntary or an involuntary hold. And they can determine how long it's going to be. And interesting thing is that if they're in those rooms and they're locked only in one way, the one-way locks, in order to shut a door, there has to be a doctor's order to close the door for 24 hours. The order has to be redone every 24. So that's kind of the hospital process behind it. So we bring them into this. Organic disorders, organic brain syndrome is a temporary or permanent dysfunction of the brain caused by disturbance in the physical or physiologic functioning of the brain tissue. Causes would be sudden illness, traumatic brain injury, seizure disorders, drug or alcohol abuse, overdose, or withdrawal. Diseases of the brain such as Alzheimer's and meningitis. Altered mental status can arise from hypoglycemia, hypoxia, impaired cerebral blood flow, like a stroke, hyperthermia or hypothermia, so hot or cold. In the absence of a psychologic cause, altered mental status may be an indicator of psychiatric disorder such as bipolar disorder. Right? We are not going to diagnose somebody as bipolar because it's on our job. We can do hyper and hypoglycemia. We can do hypo and hyperthermia, but we cannot diagnose true issues like that. Psychological disorders that impair bodily function when the body seems to be structurally normal. Examples would be like schizophrenia, anxiety conditions, and depression. All right. It's not my place to ask if any of you guys have schizophrenia. All right. However, there are voices in your head that say a lot of mean things to you and tells you like you're stupid, you're dumb, you're worthless, you can't do this, you can't do that. So what I usually do with my students, and I can't do this with you guys because obviously you guys are virtual. Go onto YouTube, find a YouTube video of schizophrenia, the patient, what it feels like to be a schizophrenic. Close your eyes and try to think of 10 things you want to shop for at Walmart. Let's see if you can come up with a list of 10. With all these voices in your head. All right. We
Things I
did that
want,
in all my
things I
other
need.
classes.
It is
Was-
like impossible.
Yeah. So I always ask my students in person, what I would do is I would play it in the classroom and have you guys come up with a shopping list of 10 things you want to buy at Walmart. And I make you listen to this video for like 5 minutes.
What was the name of the video again?
It's just it's something schizophrenia. Just like the
All right.
life of being a schizophrenic or something. What it's like to be schizophrenic.
All right, so you made them watch the video, and then you had them list 10 things
No.
in their brain.
You got
Wow.
it while with your eyes closed, while listening
Yeah.
to the voices in your head. Come up with 10 things you want to shop for at Walmart. Try it out. Not right now, because I'm going to finish the lecture here. Try it on your own time.
Oh, I can't stop thinking about it now. Those are the voices in my head. God
Right.
damn, you can.
So I usually have my students do that in person, and it's very rare that I have a student that says, I thought of all 10. I'm like, no, you really didn't. Because it's not an easy thing to do when when your own head telling you that you suck at life. So, little homework project for you guys. All regular EMT skills, patient approach, assessment, patient communication, obtaining history, providing care, are all used in behavioral crisis. We still have to get an assessment. All right. So scene size up, scene safety. The first thing to consider are is the scene safe for you, your partner, your crew, your patient, in response to the environment. Is the situation potentially dangerous for you or your partner? Do you need immediate law enforcement backup? If we're going to a psychiatric call anyways, we should not be going in without PD anyways. All right, we really shouldn't be. Wait for law enforcement to get on scene. Right? Does the patient's behavior seem typical or normal for the circumstance? You ever seen somebody on meth?
Yep.
Yep.
I did last night coming home at the corner
You did
store
meth
by
last night?
no, at the Poland, you know that corner store by the Poland company there, Poland Spring Water Company? There were 6 people there and they were all whacked out on meth. I'd never seen it before.
It's
I left.
it's definitely different.
Yeah.
I had a guy that was chasing a fly once. That was pretty interesting. So take appropriate standard precautions and request additional resources you may need. There are legal issues involved too, like crime scene, consent refusals, things like that. If they're not mentally capable of making a decision, you deem them incompetent, then they need to go to the hospital. Whether it's by law enforcement, you physically put them on the stretcher yourself. Mechanism of injury, nature of illness. Note that medications or substances that may contribute to the complaint or maybe for treatment of relevant medical conditions. So again, look for the medical history. Helps out quite a bit. Form a general impression. Obviously, begin your assessment at the doorway or from a distance. Never turn your back on a psych patient. Please, please, please never turn your back. Right? They can hurt you. And never put yourself in a position where you are being blocked by something, an object, or the patient about getting out. Always make sure you have an exit behind you. Right? Rapid physical exam. Observe the patient, AVPU, establish rapport with the patient. And most medical or trauma situations will include a behavioral component somewhere. Airway breathing, circulation. Obviously, use pulse oximetry, ensure the patient's breathing. Circulation, obviously, assess rate, rhythm, and quality of the pulse. Evaluate for presence of shock, bleeding, and then the patient's perfusion status by looking at skin color, temperature, and cap refill. So a lot of the same stuff, all the same basic assessment ABCs on your primary. Then we're going to do our transport decision. So unless there's an unstable patient with medical problem or trauma, prepare to spend time with the patient. Have a chance to talk with them. Right? They may just be calling you just to have a conversation. All right, we get that a lot with the elderly. They may just call 911 because they're lonely. They, oh, she's crazy. Take her to the hospital. She's not crazy. She's just lonely. She needs someone to talk to. She needs an at-home nurse or needs to be somewhere where she has family. We had one of those in Shapley that we used to go to all the time when I was running over there a lot. When I would just, she'd always call 911. We go there. We sit there for like 45 minutes. So they're still available for calls. Just sit down, have a conversation with her, make her something to eat. Then we just go home after. Or back to the station. So investigate the chief complaint, obtain a sample history, consider 4 major areas as contributors. Is a patient central nervous system functioning properly? Okay, what can deviate a central nervous system issue?
TBI?
Yeah, TBI, stroke, right?
Head injury.
Trauma, head trauma, like you mentioned, TBI. Are hallucinogens or other drugs or alcohol a factor? Give me a natural hallucinogen, and we can name one off.
Mushrooms.
Mushrooms.
Yep. What's one that you can buy in a store?
Marijuana.
Salvia.
Huh?
Salvia.
Something you can snort.
Oh.
Huh?
Bath salts.
Nutmeg.
Nutmeg.
You say nutmeg?
I did.
Jesus.
What the hell?
Nutmeg
Great.
snorted.
Now I gotta think of Walmart, 10 items. Now I gotta go buy nutmeg.
Nutmeg
Yeah,
is a natural.
a whiff of it.
Nutmeg is a natural hallucinogen if you snort it.
I'll
Fred,
bring it
if
to
I hear an
class.
ambulance call later to Ossipee for because some guys snorted nutmeg, I'm gonna know it's you.
I'm gonna bring it to our practical. We're all gonna do it
Oh,
together.
Oh, great.
I just see you guys all snorting lines of nutmeg on the table.
We'll have brown under our nose, not white.
Great. Morgan's gonna be like,
We're probably
what the
brown
hell?
nosers.
Morgan's gonna
In
be
the
so lost. Yeah.
in the state of Maine, hallucinogenic mushrooms are legal.
Wouldn't surprise me.
What state?
In Maine,
Yeah.
can buy them.
No, they're not legal in Maine.
you can buy them at any of the shops that sell the
Marijuana.
marijuana. You really can.
So what about like I always can't pronounce it. MDMA. Back in like the 70s, that was considered like a spiritual medicine.
Oh, I just got attacked by my dog again. All right.
Is that
So,
ecstasy or is that the ayahuasca? MDMA.
Ecstasy. Yeah.
Okay.
Whatever the.
So as part of your sample history, you may be to elicit information that would be helpful to hospital staff. So try to get the information. If you see bottles laying around, grab them. Yeah, bring them back with you to the hospital. In geriatric patients, consider Alzheimer's or dementia. Also look at their medication regimen as well and make sure they're actually taking their meds like they're supposed to. And use reflective listening. Like truly listen to your patient. All right. Questions to ask evaluating mental health. Does the patient appropriately answer your questions? Does the patient's behavior seem appropriate? Does the patient seem to understand you? Is the patient withdrawn or detached, hostile, friendly, happy, depressed? Things like that. You guys can read right down through all these here. But just have an understanding of what you need to be asking your patient. Remember, we're tailoring our assessment. All right. So physical examination in an unconscious patient, begin with a physical exam, head to toe. Let's find out why. A conscious patient may not respond to your questions. May not want to talk to you. They could be completely checked out. All right. We'll get more to that here in a little bit. When we start getting more into our processes here. You can tell a lot about a patient's emotional state from facial expressions, pulse rate, respirations, and a blank gaze or rapidly moving eyes can mean central nervous system dysfunction. All right, so tears, sweating, blushing may also be significant indicators of state of mind as well. Bath salts are, ugh, those patients are quite interesting. I have some stories about those I'll tell you guys in the offline sometime. So transport decision, have law enforcement or firefighters accompany you if possible. If the patient is handcuffed inside the back of your ambulance, law enforcement has to be in the back with you.
Yep.
Not following behind you. They have to be in the back. So make sure they well know that before they decide to get out. If they're going to handcuff them to your stretcher, they will be in the back of the ambulance with you. It is required. Right? Maybe a specific facility to which the patient's behavioral health emergencies are transported. Right? Around here, it's a local hospital. Every hospital has a psych unit of some sort. Let's say psych unit. They have a psych ER. In the ER, they have a psych bed usually. I shouldn't say psych unit. Like main med, they have like, I want to say it's like an 8-bed psych ER you can go to at Maine Medical Center, but they're not going to keep them there. They're going to ship them out. Some hospitals have Jerry Psych though at the facilities itself. Like Maine Med had Jerry Psych for a while. I don't know if they still do not. Frisbee has one in Rochester, or they have Jerry Psych. Other than that, they're going to be going to different hospitals like Hampstead, things like that. Spring Harbor as well. Transport by ground. These are not patients that are flown. All right. Law enforcement. It's sometimes easier if law enforcement takes them, especially if they're combative. Make the patient feel comfortable if they're not. Never let your guard down. Just be on your toes. Be ready. Situational awareness. If restraints are necessary, reassess and document every 5 minutes for vitals, respirations, pulse, motor, sensory functions for all restrained extremities. When you guys see Morgan on one of the Sundays coming up here, ask him to show you how to properly restrain someone to a stretcher using cravats. All right, interventions. So diffuse and control the situation. All right, so bring it down, get them, but make sure that you also understand, never let a psych patient have the upper hand. Okay. The best treatment is to be a good listener. Listen to them. Intervene only as much as it takes to accomplish a task. No more, no less. If a patient is pharmacologically restrained, if you think a pharmacologic restraint is necessary, call ALS as early as possible. We carry Versed, Valium, Ativan, ketamine, things like that we can utilize, Haldol, to be able to knock somebody down as a chemical restraint versus using non-chemical. The best method is not chemically restraining somebody. There's a lot of airway compromise issues as well with that. So we try not to do that. Communication and documentation, give the receiving hospital a dance warning, like on the scene, have somebody call them or have dispatch call them and say, we're bringing in a combative psych, so they know to prepare and get security ready. A lot of times if the patient's that bad, they're very violent, then PD will PC them in a cell until they calm down, or they'll sedate them right there at the hospital. Intubation is not even far-fetched either for patients that are completely combative, because you just basically knock them down and then just intubate them and then control them that way. So document thoroughly and carefully if restraints are used. Say which types were used and when they were used and why they were used in your narrative. So acute psychosis is a state of delusion in which a person is out of touch with reality. Affected people live in their own reality of ideas and feelings. So common causes of psychotic disorders episodes would be mind-altering substances, intense stress, delusional disorders, and schizophrenia. For a while, there was a private school in a nearby town from here that had a lot of acid going around. And it was a very bad batch of acid to the point where some nurses got punched in the face at the hospital when they were transported. So that's still around too. Schizophrenia is a complex disorder that is not easily defined or easily treated. The typical onset occurs during early adulthood, with symptoms becoming more prominent over time. Influences thought to contribute to the disorder would be brain damage, genetics, and psychological and social influences. Other symptoms would be delusions, hallucinations, a lack of interest in pleasure, and erratic speech. Some guidelines for dealing with psychotic patients. Determine if the situation is dangerous or not. Clearly identify yourself and be calm, direct, and straightforward, and maintain an emotional distance. Do not argue. Please do not argue with them, okay? Even if you know you're right, don't argue, because it's just going to make things worse and things are going to become escalated, which you don't want to happen, right? Explain what you would like to do. I'd like you to come sit down on my stretcher. Can we go for a walk out to the ambulance? You know, do you mind if I take your blood pressure? Do you mind if I have a conversation with you? What medications do you take? You know, have those kinds of conversations with them. Involve people whom the patient trusts, such as family or friends, or to gain the patient's cooperation if need be. Excited delirium, also known as agitated delirium or exhaustive mania. Delirium is a condition of an impairment, in cognitive function that can present with disorientation, hallucinations, or delusions. Agitation is a behavior characterized by restlessness and irregular physical activity. Patients that have excited delirium, agitated delirium, usually require ketamine. Those are patients that are probably going to be chemically sedated. Symptoms would be hyperactive, irrational behavior, vivid hallucinations, hypertension, tachycardia, diaphoresis, and dilated pupils.
Forget the nutmeg. Never mind.
Oh man. If you you can also take Mucinex DM, and then you can get high off that too as well.
Jesus, Mary.
But it has to be Mucinex DM though. If it's a regular Mucinex, it's not going to work.
Do you have to snort it?
No, you just take a bunch of pills.
I bet you have to get those behind the pharmacist now.
They are, yeah. Those are not over the counter anymore.
I
Those you have
thought
to have
growing
like
up being
IDs.
naive. I thought growing up being naive to all this stuff was I was being punished, but I'm so glad I didn't know about all this shit when I was growing up.
I kind of wish I could have taught your toxicology class because I like teaching this stuff.
I
have a
didn't
lot
know
of
about
interest
it
in-
then, and I don't know about it now. I'm like the drugs that people use they blow my mind.
So, I mean, off topic because I don't want to keep you guys here till 10 if I don't have to. It's pretty crazy stuff that's out there. I mean, people are putting petroleum products in their veins. Right, crocodile is one of them, and it literally ate your flesh.
Just the
To get
bath
high.
salt thing alone, someone had to have like whoever the person was that discovered the fact that they could get high off of it, and then someone was like, "Hey, this was awesome. Let's try it," and then it manifested people eating flesh, other people like, and just going.
It's so bad.
Monstrous. I'm like,
bath
what?
salts are so dangerous, man. Let me tell you, when they started making the come around with that kind of stuff, we were carrying extra Versed because it's the only thing that could take someone down. Was IM Versed like 10 milligrams to start and then keep going. It's like superhuman strength, crazy, like insane. I saw more bath salt overdoses in Somersworth, New Hampshire than I did anywhere else.
What is the drug that's in that?
It's bath salts that you would buy.
To take a bath in?
Yeah, like bomb baths, those bomb things.
Yeah.
Those.
That's all it is.
And what were they doing? What were they doing with it?
Smoke it.
Yep.
So you're talking about the ones that dissolve, that get all fizzy.
Yeah, bath salts.
You go to Bath and Body Works and you go in and you say and you look anything that's like in a
ball
or like chunks or whatever. Yeah. Yep. They just crush it and smoke it.
I thought bath salts was a slang term for something else.
Me too.
No.
I thought it was like crank or something.
That's like speedball.
Yeah.
Obviously, I don't do bath salts because I don't even know what the hell they are.
You probably have them in your bathroom. Like
one of the things that we see a lot of. One of the things we're seeing a lot of lately is the use of cocaine and heroin or epi, or people shooting up with epi afterwards. That's what they call speedballing, where they get that. where they get that high and then it reverses and goes back to them being like wakes them back up again and they're like ready to go. There's so many different combinations that are out there. Because remember, fentanyl was big, and then carfentanil came out, and then it's insane.
Yeah, I don't.
There's so many different things out there people get high off of nowadays.
Like huffing
How about
paint
parties?
with what?
Going to a party, nebulizing vodka.
At a party?
Yes.
So yeah, they have it's called Borg. They have all the college campuses, all the kids have Borg. It's basically just like anything you can put in your gallon of fucking juice. I'm like, huh? Like,
How about
that's disgusting.
another thing that I saw when I was working for Middlebury EMS in Vermont? We got a lot of patients that would soak tampons and shove them up their butt with alcohol.
Yeah, we had a colonoscopy for that, but not a tampon.
Christ.
Yep.
I guarantee the kid saw it on YouTube or something, or a movie, and decided it was a good idea to do it by himself. His poor mother had to call 911. He drank a bottle of wine.
The anal cavity is very, very vascular, so it sucks in, and people die from that. So one of the things that was called in college years is called butt chugging, where they take a beer bottle and stick it in there and let it
funnel.
Or a funnel. And we get called to that kind of stuff. Patients that were intoxicated because they shoved alcohol in their butt. So again, a little off topic from here, but I want you guys to understand it's out there. And if people can smoke it, they're going to. If people can drink it, they're going to figure out how to do it. Right?
Yeah.
And it's there. So be ready. And that's kind of a toxins lecture. It's not really excited delirium, but again, do not leave your patient unattended. With excited delirium, bath salts, crazy things like that. Use careful interviewing to assess the patient's cognitive functions, determine the patient's ability to communicate early, and observe the patient's appearance, dress, and personal hygiene. Look at all of it. See how they are acting, how they are living, and would it be considered the norm? If the patient appears to be experiencing an overdose, take all medications and bottles of illegal substances with you to the medical facility, right? The patient should be transported to the hospital with behavioral health facilities, right? Refrain from using lights and sirens because they'll agitate them even more. If the
Hey,
patient's
Kevin,
agitation continues,
wait a minute. You're not really going to, I mean, like if they're snorting coke, we're not going to take the coke to the hospital, are we?
No, let PD handle that.
All right. So we're not taking
I'm saying more if they're.
It said illegal substances, then I'm thinking we're not taking that. We'll take pills and bottles.
But if it's in a jar, take it with you.
Okay. All right.
Bring it with you to the hospital, get it to the hospital. They're going to dispose of it anyways. They're going to test it too to see what else is in it.
Okay.
They have the abilities to do that. Just like fentanyl. If you get fentanyl on your hand, it's not going to hurt you, right? If you pick it up. If you snort it, different story, right? It's not meant to be snorted if you inject it. But if you get fentanyl on your hand and you think that you're going to die from that, you're not. It's not even going to affect you at all. It's not going to absorb through your skin, right? It's not a topical, right? It's not a transdermal medication, right? So I want to make sure that unless it's in a patch form, then it could be transdermal. But if you see powder, if you happen to go into a house and you accidentally get powdered fentanyl on your finger, just wash it off. It's not going to, just don't snort it.
Yeah, just don't sniff it. Yeah.
Don't rub it on your gums.
Yeah.
Right. So excited delirium can lead to sudden death from sudden sudden cardiac arrest, physical agitation throughout result from metabolic acidosis, physical control measures like including tasers, stimulant drugs, and positional asphyxia. Restraints or pre-hospital restraints reduces the possibility of patient injury, the potential for injury to EMS providers, and allows for a safe, appropriate treatment for an unconscious patient. If I have a patient, even in patients that are, if I intubate somebody and they're unconscious and I put a tube down their throat to help them breathe, I'm going to restrain them. The last thing I want is for them to wake up and reach up and grab the tube and pull it out. Right? Restraints are not a bad thing. right? So the NAEMSP recommends that every pre-hospital patient transport provider create and follow a pre-hospital patient restraint protocol, right? So follow your state's protocols on how you can restrain patients. So I'll have Morgan go over that with you guys up there. Risks associated with patient restraint and proper use of restraints can lead to life-threatening conditions, including positional asphyxia, aspiration, severe acidosis, and cardiac arrest. Restraint of a person without authority in a non-emergency setting can result in legal action, assault, battery, false imprisonment, and violation of civil rights. Okay, so something to think about with restraints on that. So I just lost my train of thought. I had something as I mentioned with that too. I'll come back to it. Restraints are only used to protect yourself or others from bodily harm or to prevent the patient from injuring himself or herself. When I first got my EMS license, okay, it was appropriate to put a psych patient combative on a backboard and put another backboard on top of them and sandwich them together.
What?
That was allowed when I first got my EMS license.
Look at that. Must have been fun.
Right, placing a surgical mask over the patient. I had a patient one time that I put 13 straps on a patient, 13, with 2 backboards, 3 surgical masks, because he ate through every one of them.
Yikes.
Right. Please do not take a pillow and place it over their face. Right. That is not allowed anymore. Because obviously in the backboard thing, patients were dying. That's why I never had a patient die on me from that, but that protocol changed about maybe 3 years after I got my EMT license. You can no longer sandwich a patient with a backboard.
Jeez.
Right. Involve law enforcement personnel if you are called to assist a patient in a severe behavioral crisis. Right. You may need them. They have the power to detain. They have the power to arrest. We do not. All right. So utilize them if they need to. So the process of restraining a patient. Once the decision has been made to restrain a patient, you should carry it out quickly. Right. Ideally, you should have 5 people should be present to carry out the restraint. 1 responsible for each extremity and 1 responsible for the head. Right. There should be a team leader who directs the process of the plan of action before you begin. So use minimum force necessary to control the patient. So the level of force will vary depending on the following factors: the degree of force that is necessary to keep the patient from injuring self and others, the patient's sex, size, strength, and mental status, including the possibility of drug-induced states. So the type of abnormal behavior the patient is exhibiting as well. You really truly do need 5 people. You really can't take someone down with 2 people and physically restrain them onto a stretcher. It's just not going to work. Right. So you or your partner should talk to the patient throughout the process. Right. Let them know, we're going to tie down your legs, we're going to tie down your arms, things like that. Never put a patient face down. Proning is bad. You never do that. Treat the patient with dignity and respect at all times. You'd be surprised how far you can go when you start treating a patient with dignity and respect. If possible, the provider of the same gender should attend to the patient. Now, if you don't have a female patient, you got to do the best you can. Wear appropriate barrier protection during patient restraint activities as well. Avoid direct eye contact and respect the patient's personal space until necessary. Never leave a restrained patient unattended either. And you want to do a 4-point restraint. So you do both arms, both legs, preferably for the uncooperative patient. So what you're going to do is you're going to take your right hand or left hand and you secure it to the top of the stretcher. Right. The other one goes down to the bottom, down to the side rail, and you do each foot. Okay. Respiratory and circulatory problems have been known to occur in combative patients also who are restrained. That's why we talk about that positional asphyxia. All right. So restraints applied in the field should not be removed until the patient is evaluated by the receiving facility. Right. Because you may get there and to the hospital, and they may have to chemically sedate to get them off your stretcher and onto the bed. Right. So there's steps in skill drill 23-1 for implementing a 4-point restraint, and then a 2-person restraint technique is an option if allowed by protocol. It's not easy with 2 people. I'm gonna tell you that right now. Violent patients account for only a small percentage of patients undergoing a behavioral crisis. So we're going to get more to those here in a second. So assess the level of danger on the following risk factors: history and posture. So any previous history, overly aggressive, violent behaviors. And as far as posture goes, how is the patient sitting or standing? Is the patient tense, rigid, or sitting on the edge of his or her seat, like ready to pounce and like take you out? Right. So look for those different indicators of body language.
Clenched fists, all that stuff.
Yeah, clenched fists, everything. Yeah. With the scene, is the patient holding or near potentially lethal objects such as a knife, gun, glass, pokers, bat, right, near a window or a glass door? So again, if you see anything, get out, leave. Right. Vocal activity. What kind of speech is the patient? Are they being just verbally abusive? Are they loud, obscene, erratic, bizarre speech patterns usually indicate emotional distress? The motor activity of a person undergoing a psychiatric emergency may not be the most telling factor of all. So again, patient may be watching. A patient requiring careful watching is one of who would have like a tense muscle, clenched fists, glaring eyes. If they're pacing back and forth, they can't sit still, is fiercely protecting personal space, things like that. So you got to keep an eye on those. Some other factors to consider would be poor impulse control, a history of truancy, fighting, or other uncontrollable temper, history of substance abuse, depression, which accounts for 20% of all violent attacks, and a functional disorder. If the patient tells you voices are telling him or her to kill, believe it. Okay. If the voices are saying it, believe that they are saying it, and protect
Okay,
yourself.
so like when we're going into the scene, this is I'm kind of walking through a scenario, and someone has called on the patient we're going to see. So the person that called 911, whether it's a spouse, relative, whatever, they call this person's acting mental or not right, and that's when you go in to do like history. That person's going to be agitated, probably at the person that called, right? And so now you got to try to separate the two of them or the people, and then try to gain the trust of the person that's there, try to calm them down, and then get the information from the person that called. Because sometimes the person that's calling may not be the most stable person either, right? So, and then when the cops showing up, all the lights, you just have to talk them down. Just bring them down.
Yep. All right. So suicide. Depression is the single most significant factor that contributes to suicide. It is a common misconception that people who threaten suicide will never commit it. Right. So threatening suicide is an indication that someone in a crisis that he or she cannot handle alone. Immediate intervention is definitely necessary. So they have suicidal ideations. They've made threats, whether that be through text message, note, verbal, anything. If a threat has been made, it needs to be looked into. All right. The other thing to think about as well is homicidal. Do they have threats to hurt other people as well? All right. So be alert for the warning signs: feelings of sadness, deep despair, or hopelessness that suggest depression. Appearing detached from the situation, inability to talk about the future, suggests of suicide. Specific plans for committing suicide or related to death. All right, so here's I honestly cannot read that at all. My screen's too small. But here's some risk factors for suicide here. Table 23.3 should be in your ebooks or your textbook if you have one. So consider these additional risks, right? Are there any unsafe objects in the patient's hands or nearby? Is the environment unsafe? Is there evidence of self-destructing behavior? Is there an imminent threat to the patient or others? Okay, suicidal ideations, homicidal ideations. Right. And is there an underlying medical problem? Has there been trauma? Suicidal party may also be homicidal, like I mentioned before, so keep that in mind as well. Are there any cultural, religious, or social beliefs promoting suicide? Was anything made on Facebook? Was something happen? All right. Do you guys need a break, or you just want to finish this up? We have about maybe 15 slides before the review.
Let's
Let's
just
finish
keep
it up.
on going.
All right, let's power through it then. So post-traumatic stress disorder and returning combat vets. PTSD can occur after exposure to or injury from a traumatic event. Examples would be sexual or physical assault, child abuse, or serious accidents. There are triggers that can set people off. Okay, so when someone has an episode, while having a conversation, ask them, what are your triggers? What happens? Or talk to family about it. What triggers them to set themselves off to become violent like this or depressed like this or whatever it may be. Okay. Natural disasters, war, loss of a loved one, and stressful life changes. So PTSD is necessarily not the result of one isolated or recent event. An estimated 7 to 8% of all of the general population will experience signs of PTSD at some point in their lives. So military personnel who have experienced combat have a high incidence of PTSD. Okay. What they don't mention on here, fire and EMS, and the things that we have to go through as well. PD, right? It's not just military, even though military has a high incident of this, so don't we? All right. So signs and symptoms of PTSD include feelings of helplessness, anxiety, anger, and fear. So people with PTSD frequently avoid things that remind them of trauma. Okay. It could just be as simple as a smell, a sight, a sound that could set somebody off. Right. So heart rate increases, pupil dilate, systolic blood pressure increases. Which autonomic nervous system is this? What's going on here autonomically? Nervous system arousal. Which system?
Sympathetic.
Sympathetic. Good job. Awesome. So senses are sharpened, mental acuity is heightened, often relive the traumatic event through intrusive thoughts, nightmares, or even flashbacks. I've seen this in the veterans' homes for the elderly before. We've gotten called for EMS before for psychiatric disorders, and they're having flashbacks of some war. Right? It's not good. It's and they're dangerous. We got to find a way to get them back to the reality and get them the treatment that they actually need. Dissociative PTSD occurs when a person attempts to find an escape from constant internal distress or particularly disturbing events. Alcohol and or drug use is common with this. Veterans have an increased risk of suicide as well. Veterans may also develop a variety of physical conditions related to injuries sustained during combat, as well as from unfocused pain that is not associated with any specific body part. Combat veterans have a higher incidence as well for TBIs sustained from trauma secondary to an explosion of an improvised explosive device or an IED. So eliminate excess noise, refrain from touching or doing anything to the veteran without explanation, and keep your diesel equipment far away as well. So if you have diesel fire trucks or obviously, or diesel ambulances, that smell can trigger stuff as well. Caring for the combat vet. So the returning combat vet is a person who will require a unique level of understanding, compassion, and specialized attention. Be careful how you phrase your questions. Use a calm, firm voice, but be in charge. Respect veterans' personal space. Ask about suicidal intentions, because we have to know, and limit the number of people involved. If they have a pet, right, that is there, like an emotional support dog, they can go in the back of the ambulance, just so you guys know. Okay, so you
What
can
about
bring
an
them with
emotional
you.
support alligator?
I would love it.
Right. That was on the news recently. The guy wasn't allowed to go into the game with his emotional support alligator, and it was a legit alligator
That's
that the
insane.
guy has as a pet.
It works. It makes them happy.
Yeah.
So military personnel are trained to use weapons and resourceful at improvising weapons as well. So ensure that there's nothing the patient can access and use the weapon. When I first got my EMT license, I carried a stethoscope. I had trauma shears. I had pens. I had, you name it. I probably had it hanging off my belt or my pocket. Right. What do I carry now? A pen.
Nothing. No, maybe a pen. Yeah.
A pen and maybe a stethoscope. If it's psych,
It's not hanging from your neck.
Yep. And if it's a stethoscope, and if it's we're going to a psych, it stays in the truck. I don't carry trauma shears anymore because I've had them pulled out on me and someone tried to stab me with them. Happened once, never again. All right. I don't wear radio straps anymore because people can grab it and pull you. A lot of things have changed over time because people have done something to me at one point in time or another. So, all right. So medical considerations are medical legal considerations. The medical legal aspect of emergency medical care becomes more complicated when the patient undergoing behavioral health emergencies. So once you have determined that the patient has impaired mental capacity, that's what I was looking for, is capacity. You must decide whether he or she requires immediate emergency medical care. A patient in a mental or mentally unstable condition may resist your attempt to provide care. Do not leave the patient alone and request law enforcement to handle the patient. Guess what? They're going to the hospital. They also need consent. Implied consent is assumed with a patient who is not mentally competent to grant consent. Right? So consent matters. They're not always clear cut in behavioral emergencies. If you are not sure, request the assistance of law enforcement personnel and guidance from medical control. If I'm going to take someone from their home who is not making sense and they have lost their capacity, right, to make decisions, I'm going to do this with medical control's approval, even as a paramedic. Why? Because I'm going to have that consultation. And then law enforcement will be on the same page. Right? Don't put yourself in a situation. Medical control will be your friend. Limited legal authority. The EMT has limited legal authority to require or force a patient to undergo medical emergency care when a non-life-threatening emergency exists. A competent adult has the right to refuse treatment, even if life-saving care is involved. Right? But if they are altered, that changes things. If they're unresponsive, it becomes implied. In a psychiatric case, or a court of law would probably consider your actions in providing life-saving care to be appropriate. A patient who is in any way impaired may not be considered competent to refuse treatments or transport. Always maintain a high index of suspicion regarding the patient's condition and assume the worst and hope for the best. Err on the side of treatment and transport if you can, and carefully document the patient's statements and behavior to support your actions. All right, let's do some review. We'll call it a night. Right? A behavioral crisis is most accurately defined as
D.
Or I'm not looking at the chat group, so
I'm saying D, but I haven't read them all yet.
I'm
That's
saying
fair.
B.
B.
B. All right,
I'm
B
gonna say
it
B
is.
then.
I like it. B
Read
is.
from bottom up.
Depression and schizophrenia are examples of what? Schizophrenia and depression are examples of what?
A. Functional.
A.
Yeah, functional. Good. Number 3, when assessing a patient with behavioral crisis, your primary concern must be your
D.
primary concern.
D.
D.
D it is. Number 4, general guidelines to follow when caring for a patient with behavioral crisis include all of the following except
D. You don't want to argue with them.
Yeah, I'd say D. as
Yeah,
well.
D. I love to argue, but definitely D.
So the
I
answer
think
is B.
B.
Rapidly transporting the patient.
Yeah, take your
Did
time.
you want to calm them down? Take your time.
Yeah. Except.
Guidelines to follow.
Big word.
Patient would be.
All right. Number 5. Reflective listening. An assessment technique used when caring for patients with an emotional crisis involves what?
D.
Listening to the patient without speaking. B.
D.
B is in boy.
No, I saying D as in dog.
I see D as in
Yeah, B as
Delta,
in
B as in Bravo.
Bravo.
All
Dog.
right.
D is
Isn't
Right.
it?
We're going to go with the dog. Reflective listening is a
big.
technique in which you repeat in question form what the patient tells you.
I'm gonna argue.
Which of the following patients?
Reflective. Think of the word reflective.
Which of the following patients is at highest risk for suicide? Highest.
I'm gonna go with C.
A.
All right. Answer is C.
C. Good job.
Number 7.
That's a weird one.
Oh yeah, it was men, not women. I was
It's a
thinking,
weird
oh
one.
yeah.
When caring for a patient with an emotional crisis who is calm and not in need of immediate emergency care, your best course of action is to do what?
C. To obtain
C.
consent.
C.
I would do C, but it's probably A.
Let's see.
Yeah.
Get right. Oh. Hold on. Number 8. When physically restraining a violent patient, the EMT should do what?
Check circulation in all extremities. The patient is prone. Or A. Actually, maybe A.
A.
I changed to A. I'm going with A.
A.
All right. Hey, it is.
Yeah, because they
All
said
right.
never put them in prone, so you wouldn't. That wouldn't have been B.
Yeah. Number 9. Upon arrival at the residence of a young male with an apparent emotional crisis, a police officer tells you that the man is acting bizarrely. You find him sitting on his couch. He is conscious but confused. He takes medication but cannot remember why. His skin is pale and diaphoretic, and he has noticeable tremors to his hands. Your first rule out. You should first rule out what?
A.
A.
Good. Keeping the medical. Hypoglycemia. And number 10, which of the following signs is least indicative of a patient's potential for violence?
B.
Least indicative.
Think of
B.
All right. B it is. All right. Let me just shut this down really quick.
That's funny when we were talking about like PTSD. I mean, I was in the army and I don't have